we were devastated when Dr. Sabbagh left us in Arizona, went to potentially greener pastures in Las Vegas. Although we're happy that he's back in Arizona. We really need an expert like Dr. Sabbagh. That was really outstanding, Marwan. Thank you so much. Okay, so we're going to entertain some questions from the audience and also from the online audience. We have about 20 minutes before Dr. Sabbagh has to leave. So let's take advantage of this time. So I'm going to start off while yeah, go ahead, please.
So are biomarkers and genetic markers?
Let me take the microphone to you.
Testing sounds like that seems to be the baseline from which algorithms go.
Okay, please repeat the question.
Sure. Are biomarkers and genetic testing the first step on getting the baseline of which direction to go?
Yes. So that's something I would do, yes. A lot of doctors still don't do those, but yes, that would be the answer.
And are those done from blood tests?
Correct.
And who would have the knowledge of what code and all of those other things to order those? Are you your movement disorder, your neurologist, or your primary care?
Primary care physicians are not quite there yet. I think specialty neurologists like Dr. Evidente and myself are aware of these and are starting to use them in our clinical practice. I think general neurologists are just kind of coming on board, but it takes them a while to get there.
Okay.
And then, so you mentioned C2N, and then you mentioned a LabCorp panel, blood panel for Alzheimer's, and then Sonora. I think in my clinical practice, I've had no issues with LabCorp and Sonora.
That's great.
Whereas C2N, I think they're working on this to be covered by Medicare and other insurance companies. Yeah.
Okay, over here we have one question.
Hi, I'm wondering if there's any studies out there that have exercise involved in being able to change the course of the Alzheimer's.
So exercise has been looked at a lot in Alzheimer's because it's one of those key pillars of brain health that everybody wants exercise to show. What it showed in a study called the EXERT study, just published last year, is that people with mild cognitive impairment were randomized to exercise or resting. And it was a prescribed regimented exercise program, and what it showed after a year is that the people who did the exercise did actually do better on their memory tests compared to people who did not. But when they looked at the biology of amyloid and other markers of the disease, it didn't move the biological markers of the disease at all. So yes, exercise is a good idea, but you cannot run your way. If you have amyloid in your brain, jogging your way out of it is not going to work, but it does help your brain.
Okay, one more question. Are there natural products that you can use as opposed to pharmaceutical?
Yeah.
Great question.
So the internet loves supplements for brain health. Loves them. There are over 75 products for brain health on the internet. I just do a search. And the answer is, because I will tell you that in your demographic, sorry, some of you are in the same demographic, Prevagen is every other commercial is Prevagen, right?
Yep.
So Prevagen has not a shred of evidence that it works. They got fined by the FDA for false advertising to the tune of $75 million. They wrote a check and kept going. The Consumer Reports just wrote a report on Prevagen last week saying, don't bother spending your money, and yet to this day it's still resoundingly popular. If you want to know the drugs that actually have some benefit, huperzine, Huperzine, A, 200 micrograms twice a day, and phosphatidylserine, 150 milligrams twice a day. There are some supplements that work. Majority of them don't have any benefit or proof of benefit.
Does donepezil work?
Donepezil is Aricept. It improves the symptoms but doesn't fundamentally alter the disease. So in other words, it makes your memory a little bit better, but it doesn't take away the disease that causes it.
What about stimulants like coffee?
So I have to tell you, Jerry, it's a funny question you asked me that. One of my colleagues got a grant from the company Illy, you know,
Yeah, sure.
Illy was studying coffee for that very reason. And it turns out because not just the stimulant effect, but they think, of course, that coffee has antioxidants.
Absolutely.
So that study's been going on in Europe, not here. But we think coffee has, some benefit on stimulant, but we can't prove the antioxidant benefit quite yet.
Yeah, they think it's not just the coffee beans themselves, but even caffeine has a positive effect, at least for Parkinson's patients. So it might be the same for Alzheimer's, for dementia patients,
Yes.
I have it's a two-part question. Thank you, first of all, for your presentation this morning. My husband has Parkinson's, so what you had to share was interesting, and there is some crossover with Alzheimer's to Parkinson's. But I wanted to ask you, first of all, if there's 127 different drugs on the market now for treating of Alzheimer's, why do manufacturers and pharmaceutical companies advertise on television their drugs? When we are lay people, we know nothing about those drugs. Why do they advertise to us? Shouldn't they be advertising to the doctors?
So that's an interesting question. There are 127 drugs being developed. They're not approved. These drugs, 99% of those drugs I showed you will not make it. Those are 127 drugs being developed for Alzheimer's disease.
So
these are separate topics. So the reason I say this to you is that those drugs are never advertised because they're still in research. Once they're approved, then the company has to decide if they're advertising to doctors, advertising to the lay public, what's called DTC, direct-to-consumer advertising, which has become very, very popular. I am not seeing a lot of DTC for the Alzheimer's drugs quite yet. People talk about DTC. Every football game you see the Skyrizis and of the world, the Humiras of the world. By the way, they're all monoclonal antibodies. I just want to point that out to you. So there are direct consumer strategies, but the companies make those decisions, not I.
Okay, well, my second question is this. I was recently reading about a study, and this is in relation to Parkinson's, about a clinical trial called UB-312, which is a drug being developed for Vaccinity out of Florida, down Cape Canaveral. And it supposedly is a drug that addresses the protein buildup in the cells, and they are saying it's one of the first drugs of its type that directly addresses the cause of Parkinson's rather than the symptoms. So I was wondering if you could address that, if you're familiar with it.
We've addressed this in previous seminars where we talk about, we had one seminar on alpha-synuclein, so the protein that builds up in Parkinson's and dementia with Lewy bodies and MSA is called alpha-synuclein. So just as in Alzheimer's, Dr. Sabbagh talked about targeting amyloid and tau, in Parkinson's we target alpha-synuclein. So the question is, if we remove alpha-synuclein from the brain, by whatever means, whether it be a drug that's being developed, or nowadays we're using GLP-1 agonists, which are diabetes drugs, as a potential set of drugs that can remove alpha-synuclein from the brain. So we're all trying to address these abnormal proteins in these neurodegenerative disorders and try to remove them. But here's an interesting question, though, in that same line of question. You talked about tau and amyloid in Alzheimer's, but is there tau and amyloid in Parkinson's dementia brains?
So turns out that some percent of Parkinson's dementia also have amyloid and tau, like less than 50%, but it's not zero. It's a certain percent do, yes.
So I guess that begs the question, can this amyloid busting therapies potentially have some use in Parkinson's dementia? If we, for instance, do an amyloid PET scan in a Parkinson's disease dementia patient or DLD patient, it's kind of say, wow, there are no amyloid.
So I don't know what's going on in the Parkinson's dementia space, but I do know they're actually having that very active consideration for treating Lewy body dementia that has amyloid with the MAPs. That's a discussion actually going on.
So I guess
Can somebody have both Alzheimer's?
Can somebody have both Alzheimer's disease and Parkinson's disease, or both Alzheimer's disease and, let's say, dementia with Lewy bodies in the same brain?
Yeah, in fact, a lot of them do.
There you go. Other questions?
Yes, of course. First of all, thank you very much. I specifically enjoyed your discussion of the differences between the categories and the specificity of which. If Parkinson's disease occurs first in terms of diagnosis, does that eliminate the possibility of Alzheimer's?
So we now recognize Parkinson's as a cause of dementia by itself. In other words, the people who have Parkinson's disease have a chance, the longer you have Parkinson's, later, more and more years you have Parkinson's, the more and more likely you are to develop dementia. What you're asking is, are they developing Alzheimer dementia, or are they just developing dementia-related Parkinson's? And the answer is that we think it could be mostly that they develop their own Parkinson's-related dementia, that eventually the pathways that affect movement also start to affect cognitive. But there is a certain percent of them also developing Alzheimer's changes as well. Less than 50%, but you can develop dementia even without Alzheimer changes.
Okay, thank you. And what does research tell us about what triggers the body to produce that type of protein to begin with?
Oh my God, I don't have that much time. So that's a long, that's a that's the day job of thousands of people trying to answer that question.
Okay,
Well,
so
no, I have to explain though. You got me going, I'm going to get going. So, amyloid, for the skeptics of the world, amyloid is the match that starts the fire, okay? Amyloid is the match that starts the fire. Anything else that happens in dementia happens because amyloid accumulates. And the way we look at amyloid is it's the early trigger of everything else. You need to understand that the biggest group in the world that gets Alzheimer's disease is Down syndrome people. So Down syndrome a generation ago only lived to 35. Now Down syndrome people live to 60, the life expectancy. We know that they overproduce amyloid in their brain from birth. They're overproducing amyloid in their brain. My colleague Cindy Lemaire at Harvard showed by age 12, you can see amyloid in their brain tissue on autopsy. We published a paper showing by age 37, their PET scan showed they have amyloid in their brain. And by age 44, they start to develop dementia. So that's what's called an overproduction disease. In other words, we know that overproducing the amyloid, Down syndrome, presenilin mutations, genetic mutations, trigger Alzheimer's in their 30s and 40s. Okay? Those are rare. Those are rare. Some people think, though, the rest of the people who develop Alzheimer's who don't have Down syndrome or genetic mutations have an impairment in the clearance of amyloid. So overproduction or underclearance. And that's what, once the amyloid starts to accumulate, and not all amyloid, specifically 42 amino acid amyloid, because people say you can go to your grave with a brain full of amyloid. That's what I hear a lot of people say, amyloid's irrelevant, you can go to your brain with a brain full of amyloid. Again, read the data. That's not the protein that's accumulating. That's a different protein. That's a 40 amino acid amyloid, not a 42 amino acid amyloid. So a different form of amyloid is considered to be benign. But the 42 amino acid amyloid, after a certain species of the oligomer, the brain starts to take off tau, inflammation, excitotoxicity, neurochemical breakdown. So overproduction or underclearance. But again, that's the day job of thousands of people trying to answer that question.
So,
Okay.
in the Parkinson's arena,
Let's switch.
Yeah, in the Parkinson's arena, we talk about pollution, pesticide exposure, concussions, living in the farm, mining, getting exposed to manganese. So these are the risk factors. Pollution, right? We talked about this being risk factors for Parkinson's. Are these the same risk factors for Alzheimer's?
So interesting you asked me that question. My boss, Dr. Reset, our new chairman, his job is to study the environmental factors that trigger Parkinson's. But lately he's been like eyeing Alzheimer's because he thinks those risks that apply to Parkinson's might be also relevant for Alzheimer's. And they're being looked at. We don't know the answer yet, but they're being looked at.
absolutely. Question?
Testing? Okay, sorry. Hello?
Yeah.
There is a question over Zoom. Let me see. Richard said, are there any other preventative measures of dementia?
So, again, all the focus is around Alzheimer's as the cause of dementia, but I will tell you, people love things like ginkgo biloba and bacopa and lion's mane and vitamin E, and the answer is vitamin E has a little bit of data, but the rest of them don't have very good data. The problem with supplements isn't that they don't work, they're just not studied well. And so, because the FDA only requires that a supplement has to be regulated like a potato chip. That's the regulatory standard of a supplement. It has to be as safe as a potato chip. So they don't have to show, no supplement that's marketed has to show any efficacy. All they have to show is it's safe. As long as it's not poisoning you, that's good enough for the FDA. You just can't make claims. You cannot make claims on efficacy unless you've actually studied it, and most companies don't do any studies to prove it. So there are a lot of things on the internet, like I said, bacopa, ginkgo, other things, that have been studied and studied and studied, don't work, but they're still marketed popularly for memory.
What about the Mediterranean diet?
Works great. So Mediterranean diet and the MIND diet and other diets have been looked at. And they showed that they can reduce mild cognitive impairment or progression. However, if you look at large groups, consensus statements, meaning the National Academy of Sciences, Medicine, and Engineering, and the Lancet Commission, both of them do not recommend any specific dietary approach. So they actually go out of their way to sidestep that answer. What they showed, the National Academy of Sciences, Medicine, and Engineering shows that they recommend exercise, cognitive stimulation, and blood pressure management as 3 things to improve brain health. They specifically don't opine on supplements and diet.
Is there any evidence to suggest that the introduction of carb Ruvo serves as a stimulus for the body to produce amyloid proteins?
You mean levodopa? Yes. No, there's no evidence that carbidopa and levodopa induces amyloid production, no. That's a falsity.
Okay, we have one more question.
What about the role of rivastigmine and memantine for slowing the progression of cognitive decline and dementias?
Yeah, so rivastigmine, galantamine, and memantine are symptomatic drugs. They improve the symptoms, much like Tylenol for arthritis. They don't fundamentally alter the disease. So you are very likely to get worse, I hope not, but likely to get worse whether you're taking the rivastigmine or galantamine or memantine. These drugs are just improve the symptoms, make you a little less forgetful, but they don't fundamentally alter the disease. But I recommend using them. I have my patients use them for, one more right there. I recommend patients take them because they do improve the symptoms. Yes?
A quick question. I didn't understand, I've not heard of Lewy body before, and I didn't understand the association between Lewy body and Alzheimer's or MCI.
Yeah. So Lewy body is the second most common type of dementia after Alzheimer's disease. I know Dr. Evidente can speak very well to this, but the fact is that the Lewy body is a inclusion or a pathological finding we find in Parkinson's disease. And the difference is that in Parkinson's disease, we think that Lewy body seems to be in one spot in the brain called the substantia nigra, whereas Lewy body dementia, those Lewy bodies are spread throughout the brain. And so the conventional wisdom is that Lewy body dementia just has a lot of these Lewy bodies all out through the brain, but their neurochemical differences, the neurochemical loss is very similar to Alzheimer's disease, and they may or may not accumulate amyloid.
So, last question for me. If a patient therefore is diagnosed with MCI, and what would you recommend at this point?
So when I see a patient with MCI, I say MCI due to question mark, right? If it's MCI due to Alzheimer's disease, first thing I'm going to do is I'm going to do the biomarker confirmation. I might do neuropsych testing. I might do the APOE genotype. I exclude, use the MRI. And in an MCI due to Alzheimer's, I'm already screening to whether they would be appropriate or reasonable for the monoclonal antibodies. If it's MCI due to Parkinson's, as you have seen a lot of your patients, or MCI due to Lewy body, I'm already talking about how I'm going to manage it, but I'm not already automatically going to a monoclonal.